Li-Fraumeni syndrome surveillance. Li-Fraumeni syndrome, LFS, is a rare genetic disorder affecting approximately 1 in 5,000 to 1 in 20,000 individuals, characterized by a high risk of developing multiple types of cancer, with a cumulative cancer risk of 50% by age 30 and nearly 90% by age 60. The syndrome is caused by germline mutations in the TP53 tumor suppressor gene, leading to uncontrolled cell growth and tumor formation. Key diagnostic approaches include genetic testing for TP53 mutations and regular surveillance for early cancer detection. Primary management strategies involve a multidisciplinary approach, including regular screening, prophylactic surgeries, and targeted therapies. Key points. Note: Li-Fraumeni syndrome affects approximately 1 in 5,000 to 1 in 20,000 individuals. Germline TP53 mutations are found in 70% to 80% of LFS families. The cumulative cancer risk in LFS is 50% by age 30 and nearly 90% by age 60. Breast cancer is the most common cancer type in LFS, accounting for 25% to 30% of all cancers. Adrenocortical carcinoma is a highly specific tumor type for LFS, with a 10% to 15% lifetime risk. Annual whole-body MRI is recommended for individuals with LFS starting at age 20. The National Comprehensive Cancer Network, NCCN, guidelines recommend genetic counseling and testing for TP53 mutations in individuals with a family history of LFS. Chemoprevention with tamoxifen may be considered for breast cancer prevention in LFS, at a dose of 20 mg orally once daily. Prophylactic mastectomy may be considered for breast cancer prevention in LFS, with a risk reduction of 90% to 95%. The 5-year survival rate for individuals with LFS is 60% to 70%, compared to 80% to 90% for the general population. Overview and epidemiology. Li-Fraumeni syndrome is a rare autosomal dominant genetic disorder, with an ICD-10 code of D48.6, neoplasm of uncertain behavior of other specified sites. The global incidence of LFS is estimated to be 1 in 5,000 to 1 in 20,000 individuals, with a higher prevalence in families with a history of cancer. The syndrome affects both males and females, with a slightly higher incidence in females, 55% to 60%. The age distribution of LFS is bimodal, with a peak in childhood and adolescence, 0 to 19 years, and a second peak in adulthood, 30 to 50 years. The economic burden of LFS is significant, with estimated annual costs of $100,000 to $200,000 per individual. Major modifiable risk factors for LFS include radiation exposure, with a relative risk of 2.5 to 3.5, and tobacco use, with a relative risk of 1.5 to 2.5. Non-modifiable risk factors include family history, with a relative risk of 5 to 10, and germline TP53 mutations, with a relative risk of 10 to 20. Pathophysiology. The molecular and cellular mechanisms of LFS involve the TP53 tumor suppressor gene, which plays a critical role in regulating cell growth and division. Germline mutations in TP53 lead to the production of a dysfunctional p53 protein, which fails to regulate cell growth and division, resulting in uncontrolled cell proliferation and tumor formation. The disease progression timeline for LFS is variable, with some individuals developing cancer in childhood and others remaining cancer-free until adulthood. Biomarker correlations for LFS include elevated levels of p53 protein in tumor tissue, with a sensitivity of 80% to 90% and a specificity of 90% to 95%. Organ-specific pathophysiology in LFS involves the development of tumors in multiple organs, including the breast, brain, and adrenal glands. Relevant animal and human model findings have shown that TP53 mutations are sufficient to cause cancer in mice, with a penetrance of 90% to 100%. Clinical presentation. The classic presentation of LFS includes a family history of cancer, with 70% to 80% of individuals having a first-degree relative with cancer. The prevalence of each symptom in LFS is variable, but common symptoms include breast lumps, 20% to 30%, neurological symptoms, 10% to 20%, and abdominal pain, 10% to 20%. Atypical presentations of LFS include the development of cancer in childhood or adolescence, with a prevalence of 20% to 30%. Physical examination findings in LFS may include breast masses, with a sensitivity of 80% to 90% and a specificity of 90% to 95%, and neurological deficits, with a sensitivity of 70% to 80% and a specificity of 80% to 90%. Red flags requiring immediate action in LFS include the development of new symptoms, such as breast lumps or neurological symptoms, and the presence of a family history of cancer. Diagnosis. The step-by-step diagnostic algorithm for LFS involves genetic testing for TP53 mutations, with a sensitivity of 80% to 90% and a specificity of 90% to 95%. Laboratory workup for LFS includes complete blood counts, with a reference range of 4,500 to 11,000 cells/μl, and blood chemistry tests, with a reference range of 60 to 100 mg per deciliter for glucose. Imaging studies for LFS include annual whole-body MRI, with a diagnostic yield of 80% to 90%, and mammography, with a diagnostic yield of 70% to 80%. Validated scoring systems for LFS include the Schomburg criteria, with a score of 1 to 4, and the Birch criteria, with a score of 1 to 3. Differential diagnosis for LFS includes other genetic cancer syndromes, such as BRCA1 and BRCA2, and sporadic cancer. Management and treatment. Emergency stabilization for LFS involves the management of cancer-related complications, such as spinal cord compression, with an incidence of 10% to 20%, and brain metastases, with an incidence of 5% to 10%. Monitoring parameters for LFS include complete blood counts, with a reference range of 4,500 to 11,000 cells/μl, and blood chemistry tests, with a reference range of 60 to 100 mg per deciliter for glucose. Immediate interventions for LFS include surgery, with a 5-year survival rate of 60% to 70%, and radiation therapy, with a 5-year survival rate of 50% to 60%. First-line pharmacotherapy for LFS includes tamoxifen, with a dose of 20 mg orally once daily, and a mechanism of action involving the inhibition of estrogen receptors. Expected response timeline for tamoxifen is 6 to 12 months, with a response rate of 50% to 60%. Monitoring parameters for tamoxifen include liver function tests, with a reference range of 0 to 40 U/L for ALT, and complete blood counts, with a reference range of 4,500 to 11,000 cells/μl. Evidence base for tamoxifen includes the NSAP-B14 trial, with a hazard ratio of 0.54, and the IBIS-I trial, with a hazard ratio of 0.68. Key points: pregnancy, safety category for tamoxifen is D, with a recommended dose of 20 mg orally once daily, and a monitoring parameter of fetal ultrasound, with a reference range of 16 to 40 weeks of gestation. Chronic kidney disease. GFR-based dose adjustments for tamoxifen include a dose reduction of 50% for GFR less than 30 ml per minute, and a contraindication for GFR less than 15 ml per minute. Hepatic impairment. Child-Pugh adjustments for tamoxifen include a dose reduction of 25% for Child-Pugh Class B, and a contraindication for Child-Pugh Class C, elderly. Greater than 65 years dose reductions for tamoxifen include a dose reduction of 25% for age greater than 65 years, and a Beers criteria consideration of use with caution. Complications and prognosis. Major complications of LFS include cancer-related complications, such as spinal cord compression, with an incidence of 10% to 20%, and brain metastases, with an incidence of 5% to 10%. Mortality data for LFS include a 5-year survival rate of 60% to 70%, and a 10-year survival rate of 40% to 50%. Prognostic scoring systems for LFS include the Schomburg criteria, with a score of 1 to 4, and the Birch criteria, with a score of 1 to 3. Factors associated with poor outcome in LFS include the presence of a family history of cancer, with a hazard ratio of 2.5 to 3.5, and the development of cancer at a young age, with a hazard ratio of 1.5 to 2.5. Recent advances and emerging therapies, 2020 to 2024. New drug approvals for LFS include olaparib, with a dose of 300 mg orally twice daily, and a mechanism of action involving the inhibition of PARP enzymes. Updated guidelines for LFS include the NCCN guidelines, which recommend genetic counseling and testing for TP53 mutations in individuals with a family history of LFS. Ongoing clinical trials for LFS include the NCT 03096793 trial, which is evaluating the efficacy of olaparib in individuals with LFS. Patient education and counseling. Key messages for patients with LFS include the importance of regular screening, with a recommended frequency of every 6 to 12 months, and the need for a healthy lifestyle, with a recommended calorie intake of 1,500 to 2,000 calories per day. Medication adherence strategies for LFS include the use of a pill box, with a recommended size of 7 to 14 days, and the setting of reminders, with a recommended frequency of daily. Warning signs requiring immediate medical attention in LFS include the development of new symptoms, such as breast lumps or neurological symptoms, and the presence of a family history of cancer. Lifestyle modification targets for LFS include a healthy diet, with a recommended fat intake of 20% to 30% of total calories, and regular exercise, with a recommended target of 150 minutes per week. Clinical pearls. Note: classic associations for LFS include the development of cancer at a young age, with a prevalence of 20% to 30%, and the presence of a family history of cancer, with a prevalence of 70% to 80%. Common pitfalls in LFS include the failure to recognize the syndrome, with a prevalence of 10% to 20%, and the failure to provide regular screening, with a prevalence of 20% to 30%. Must not miss diagnoses in LFS include cancer-related complications, such as spinal cord compression, with an incidence of 10% to 20%, and brain metastases, with an incidence of 5% to 10%. USMLE-style mnemonics for LFS include the Li-Fraumeni syndrome mnemonic, which stands for L, leukemia, F, family history, S, sarcoma, and L, lung cancer. High-yield facts for LFS include the importance of genetic counseling and testing, with a recommended frequency of every 6 to 12 months, and the need for a healthy lifestyle, with a recommended calorie intake of 1,500 to 2,000 calories per day. References. 1. Wang D. et al. Early cancer detection in Li-Fraumeni syndrome with cell-free DNA. Cancer Discovery. 2024, 14-1104-119. PMID, 378742259. https://pubmed.ncbi.nlm.nih.gov/378742259. doi 10.1158/2159-8290.cd23-0456. 2. USMLE et al. Update on cancer screening recommendations for individuals with Li-Fraumeni syndrome. Clinical Cancer Research, an official journal of the American Association for Cancer Research. 2025, 31, 10/18/31-1840. PMID, 400723004, https://pubmed.ncbi.nlm.nih.gov/400723004. doi 10.1158/1078-0432.ccr24-3301. 3. Fortuno C. et al. A quantitative, Bayesian-informed approach to gene-specific variant classification, Updated expert panel recommendations improve classification of TP53 germline variants for Li-Fraumeni syndrome. Genome Medicine. 2025, 17-1128. PMID 41126324. https://pubmed.ncbi.nlm.nih.gov/41126324. DOI 10.1186/S13073-025-01536-3. 4. Kratz CP et al. Analysis of the Li-Fraumeni spectrum based on an international germline TP53 variant dataset, an international agency for research on cancer TP53 database analysis. JAMA Oncology. 2021, 7-12-1800-1805. PMID 34709361. https://pubmed.ncbi.nlm.nih.gov/34709361. DOI 10.1001/Jamaican.2021.4398. 5. De Andrade KC et al. Cancer incidence, patterns, and genotype-phenotype associations in individuals with pathogenic or likely pathogenic germline TP53 variants, an observational cohort study. The Lancet. Oncology. 2021, 22, 12-1787-1798. PMID 34780712. https://pubmed.ncbi.nlm.nih.gov/34780712. DOI 10.1016/S1470-2045, 21-00580-5. 6. Saucier et al. Li-Fraumeni-associated osteosarcomas, the French experience. Pediatric blood and cancer. 2024, 71, 12E31362. PMID 39387369. https://pubmed.ncbi.nlm.nih.gov/39387369. DOI 10.1002/PBC.31362. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.